Hey everybody, welcome to the Home Care Forum podcast with your hosts, Sasha, Guillaume, and Emina Poricanin. Emina is going to introduce our guests this week, and we're very happy to have them. Emina.
Hi, Frank. Frank Walsh, everybody, the acting Medicaid Inspector General for New York State, the wonderful state of New York, who has graciously agreed to do this program for us. I've had the pleasure of listening to Mr. Walsh. I'll be a little more formal here on the podcast, but he's a wealth of knowledge, and we often get information from providers on areas that we're going to be discussing today. So, Mr. Walsh, thank you so much for taking the time to speak with us and anticipate good content for our
Really
listeners.
happy to be
Welcome.
here, and I hope that it's an interesting and informative presentation for all your viewers.
Thank you. So you have been on, I'll call it a press tour, but you have been speaking a lot about the revamp of the compliance program, regulations, requirements, enforcement activity, expectations. We're going to talk about that today, absolutely. However, we're going to talk about some other things as well. So I'd like to initially talk about EVV. We get a lot of questions in my law firm, Sasha as well, Sasha being an operator. There are a lot of questions still about EVV. So in no particular order, can you tell us at this point what the OMIG is doing insofar as EVV requirements for personal care providers?
Sure. So I'll go backwards to go forwards. As I'm sure that everyone is well aware, this EVV was a federal requirement, part of the 21st Century Cures Act, required all states to basically establish a statewide EVV system for personal care and home health care services. New York, in implementing that procedure, was granted a waiver of 1 year, but as of January of 2023, all personal care service and home health care service providers, with very limited exceptions, largely related to extended live-in care, were required to submit EVV data with their claim. We learned very early on, both in kind of communication with the home care and industry and with the Department of Health, that implementation was a challenge. So at that point, we agreed, to initiate a process by which we were going to, kind of work with providers to identify what were any potential barriers, to implementing these requirements, from a premise that in order for us to move into an enforcement phase, we had to ensure that there was an appropriate level of compliance in the industry. We didn't just want to go in and start enforcing requirements that we knew no one could meet. So since that transitioned, in January of 23, we have been working with the provider community. Many of your viewers are probably familiar with or have received a letter from us, identifying what we can see in our systems. And admittedly, we and the Department of Health have said, we're having challenges seeing, these submissions as well and interpreting these submissions. And we need to understand them better in order to assess compliance. What I'm happy to report and, was able to report, and we have more, success to report at the HPA conference, was we started off, we identified about 3,000 providers, that we felt were responsible, to submit EVV data. What I'm happy to report is that approximately a third of them, are in substantial compliance, very high level of compliance, above 75%.
Okay.
Of all their claims are including EVV data. And the other positive piece there is that is reflective of providers who have a claims, history above 60%. So we've got a significant number of providers that are the high billing providers that have a substantial rate of compliance.
So is
So
75% Mr. Walsh, is that kind of the number that they should currently be striving for, or was that the number that you set out at the time of beginning these audits and now you've increased your expectations because there's been more activity and reinforcement of these
it
requirements?
it really it's not reflective of anything other than a cutoff point, to sort of measure the data and to see where we are,
Okay.
by success rates. It was also reflective of, we wanted to identify who was getting there versus who are the providers out there that we really should be focusing on and making sure that we understand what their concerns are. So our outreach efforts have focused on the providers who are showing lower levels of compliance. So it's that 2/3, and it's a big number, but it's shrinking rapidly as we go along. The other thing that we're extensively involved in is development of regulations. Now, we're not the agency that is developing those regulations. It's the Department of Health. They have programmatic responsibility and, have been leading the effort there. But we jointly have been working with the provider community, kind of building in what we believe to be appropriate standards, to make sure that providers are complying and that we can meet our program integrity objectives so that sort of jump into that next phase. No news as to when we're gonna be at a point where we can say, okay, now it's time to enforce, but the hope is that we will get there soon. That's where we're at present.
Okay. Now, you may or may not be aware, but there are a lot of challenges as far as providers and this overall utilization rate because the caregivers have a hard time with the technology. Some of them have a hard time with technology overall. So it's not just this particular piece of technology they don't want to use. And then others, there's no technological problem. They just don't want to, right? Because they don't want to commit to the compliance. They know they can't meet the compliance requirement. They want the flexibility of a paper timesheet. So what do you say for providers like that? Because as their counsel, I'm often told if I don't succumb to this pressure to not use EVV, they're going to leave and just go work somewhere else. Someone who will allow them this flexibility and a slap on the wrist. And is there, to the extent you have, I don't want to put you on the spot, any recommendations you have for providers like that who want to retain that patient case, but who are struggling with this?
No, I mean it's certainly understandable, that there are challenges with the use of technology and willingness to use technology that we face. I mean, I think that kind of addressing that question, I go to sort of two ways of addressing it. The first is ultimately this is a federal requirement, and it's a condition of reimbursement of the program. So I think that it's kind of important to sort of communicate to the employees that regardless of where you go within the industry, if you're going to be servicing a Medicaid eligible population, which it's hard to think of anywhere that you're not going to be serving a Medicaid eligible population, you're going to be faced with this requirement and having to incorporate it. So I mean, ultimately, it is a condition of reimbursement for the provider, and if that provider isn't getting reimbursed, then there are negative ramifications for the operation of employment opportunity. The other thing that I would say, and I think is good to kind of message, is that this data is only being used to verify the service and that it was delivered appropriately. It's not being used for other purposes.
Thank you. It's a very
And I
important
think,
point.
yeah, and I think that is something that is a tenet in the regulations that are being developed, that it's not for other purposes. We all can help carry that message at the appropriate time.
Thank you so much. Switching gears, our providers would love to hear from you as a representative of OMIG as far as oversight and enforcement of the plans, the payors, the payors, the private insurance companies who wield so much power in their world. I'll turn it over to Sasha because we do have some questions on that topic.
Great. Thank you, Emina. And so let's speak about the MLTC's MCOs as it relates to how OMIG has oversight on them, what kind of oversight, what that looks like. Let's talk about the oversight that the plans have as relates to the providers, right? Some of the oversight, they look at claims history, and sometimes they pull money back, right? And as providers, we're unclear sometimes as where the background is on that. Where there's not transparency on that from our perspective. We can't do an audit ourselves. And also, lastly, as we understand, when the plans get the money, it's supposed to go to the state, but is that actually happening? Can you give us some clarity on that so we know that and we're secure on what kind of oversight is being applied to the plans?
So I'm not, an expert in all of the opportunities within the contract, to recoup funds. I am aware that there are often multiple opportunities for that in the network provider contracts that sort of allows for that. So I can't speak to all of the engagement, but we certainly are interested in an understanding of whether those recoveries are felt to be inappropriate. We do conduct oversight in that area. And one area that I would say that we're highly focused on is any recoveries that relate to an investigation, audit, or other identification of a Medicaid overpayment, because those are the pieces that are required to be reported to us and the Department of Health. We do conduct oversight of that and make sure that those monies are coming back to the state and that the managed care capitation rates are adjusted to reflect those recoveries, because that, in order to ensure that they have correct rate that is that's established. So, to the extent that there is a concern with regard to whether a Medicaid overpayment came back to the state, that's something that we want to hear. And I would encourage, everyone, if you're not comfortable with the process, that is an appropriate referral to us to take a look at and to make sure that everything is happening the way it should happen.
So in many instances, we will have a provider who has self-disclosed or there has been identified through potentially other channels a need to repay money. They will work with the MLTC to pay that back, but and of course, we're not asking you to name any particular MLTCs, but is it your practice? Are you seeing the MCOs and MLTCs also kind of sending that money back as well? Or has it been crickets on that end?
Yeah, so I mean, I think that one thing that we have had in our dialogue with the provider community, you mentioned our kind of outreach in that area. One thing that we've been learning a lot about is with regard to the awareness of network providers of the self-disclosure requirements of the managed care entities. And I think, sort of we have delegated those responsibilities to the managed care plans. They are required to have their own self-disclosure procedures,
Mm-hmm.
and that is supposed to be up on their websites, and their network providers be aware. So there is some greater insight and transparency. That is a subject that we are presently engaged in evaluating. Do they have it? And are we seeing those self-disclosures? The data that we have been reporting publicly suggests that we may not be. So, that is a particular area of focus of ours, for this year and the coming years.
Can you speak to this tracking and if it's low from the data, but the self-disclosure to the plans is on par or higher, I'm sure that would affect the data of disclosure directly to OMIG. So is that acceptable? Would you attribute some of the low numbers to direct OMIG disclosures to that?
I think that essentially what we're relying upon is, on the managed care side, that those self disclosures are happening and that they're being identified by the plans. We don't have insight into those relationships between the network provider and their managed care plan. So we don't necessarily see those self disclosures. One thing that we have done in the face of identified provider concerns about this happening, because the circumstances that the downstream providers often find themselves in is, I've identified an overpayment and I want to get it back to the state as quickly as possible. How do I make that happen? And how do I make sure that I'm now off the hook from OMIG coming in and saying you didn't self-disclose? And, the one thing that we've said, and I would say to your viewers, is if you're in that situation and you find that you cannot get a response from your plan, refer it to us and to our self-disclosure process. We will look and intervene to make sure that the managed care plan is fulfilling their responsibilities under the program. And, we are getting some traction, on that with, kind of providers disclosing to us, and then we're working with the plan to make sure that those. But I mean, again, as I say about the numbers, while we have seen an uptick in self-disclosures, it's not to a level that I would say is, in conformance with what is likely happening across the Medicaid program. So, out of a $100 billion program, we're seeing, somewhere in the neighborhood of 25 million in self-disclosures. And, legitimately, I look at that and say, well, is that an appropriate number given the size of the program and the scope of the program? That's what we're presently evaluating.
Is there something that we could do on the advocacy level to help get that transparency? Because as a provider, we find issues from time to time, and we do submit to the plans. But if there's no reassurance that that information is getting back, and there's no transparency into what the plans are doing, we're still left susceptible. Now, providers, what I'm leaving this conversation with is, hey, I might want to copy or blind copy OMIG with disclosure to make sure, hey, we are at least pinging them that our processes are identifying issues. From a provider perspective, you're also not leery, but you don't want to expose yourself to other unnecessary scrutiny if you have processes in place that are obviously working, let's say.
Yeah, I think that what I'm saying is, I mean, there certainly is an opportunity for advocacy here. The more eyes, the more attention this issue gets, the more likely that it is to be successful. I think that what I would say is we're working very diligently on this, certainly based upon the information that we have. The more information that we have, the better we will get. I do think that, we are likely to see a better response rate in reaction to audits that we have planned in this area. So as is generally the case, when a provider or a plan receives word from the OMIG that we want to take a look in some area, a lot of attention is given to that communication. The short term, we're trying to address it. Certainly we can help, and we're willing to do whatever we can to assist. And we're hopeful that the plans that we have in place will be successful in a intermediate to longer term horizon. But, that's a knock wood. We'll see.
Very good. Transitioning now over to LHCSA matters. More specifically, we've been talking kind of about two discrete areas. As far as LHCSAs, you know that they have been getting an influx of patients and caregivers, folks who are not too keen on transitioning to PPL as the single fiscal intermediary. And so instead of receiving their personal care through the CDPAP program and through PPL, they have chosen to go to the LHCSA. So in that regard, that program as well, Medicaid billing under that program is slowly starting to balloon because of this new influx of caregivers and hours. Is there anything on OMIG's agenda, as far as you know, to focus in on this new kind of line of cases and services that are being provided under the traditional LHCSA model?
I would say there's nothing that is specifically targeted at the LHCSAs. I mean, I think that an annual focus of our reviews has been on kind of community-based long-term care, sort of holistically. We did in response to in in response to the trends in the program and trends in the services. We did increase the number of audits that we're conducting in that space this year. We've also initiated some special projects. One that sort of I'll call out is we're looking at matches of data where we see an instance where a recipient is in a hospital or a nursing home and also billing a home health or personal care visit, which those duplicate payments should not be happening in the program. So, that's an example of a focus in this area that we are, that we're giving increased attention to in response to the trends that we're seeing in that service line. And I think that, as your question intimates, we will continue to focus in that area as in response to the trends that we're seeing, in the program going forward.
Are there any new areas, forgetting anything specific to an influx of patients or new caregivers, anything in particular about LHCSAs that from your people on the ground that you're hearing is a particular area of focus for LHCSAs?
Nothing that we're hearing as a particular area of focus for LHCSAs. But then again, our reviews are generally retroactive, so we have the benefit of time while claims are being processed through the system to evaluate them and to sort of see what's happening on the ground. Certainly people have been highlighting, this transition of assistants and recipients, the more traditional service sector as opposed to the CDPAP, world. So, as the Department of Health and others are as interested in, what's happening and what are trends, from that transition that we should be focused on. So I also have the benefit of, being able to look a little bit, in the rearview mirror, to see I need to focus on the future. But I am certain that we will, given the trends, have a increased focus here.
As we alluded to at the beginning, one of the major areas of focus that you have been speaking about and have been very, very graciously providing your feedback on has to do with the corporate compliance requirements, the revamping of those regulations, the FAQs, the interpretation, the guidance that your office has published. So at this point, I just want to turn it over to you, kind of give you an open floor to talk a little bit about that.
Yeah. So, I think that, one of the things that we've heard from the provider community, including the home care industry, is a desire to sort of understand what the requirements that they're facing. So a core function of our agency, and which kind of underlines everything that we do, is trying to sort of provide that information and education and general awareness of what the requirements are. One of the things that we very early on in our development as an agency, that we felt was important to sort of encourage a culture of compliance. We knew that it was generally present across the healthcare community, and the federal government was heading in that direction as well. So we followed tune. Our newest regulations, we're trying to enhance those requirements going forward, trying to build them more or integrate them into the operation of a provider. And I think, as with any new set of regulations that are going out, is a hesitancy or just the general question of, what are you trying to accomplish? How does it relate to me? How do I meet your requirements in the most expeditious way, so that I don't, face that negative communication from the OMIG. I think it was a little bit unexpected, but it wasn't, kind of outside of the realm of legitimacy. So, we put a lot of effort into compliance, and, a key element of that, and what we have learned, and, going back to the question that we, were dealing with, previously with regard to self-disclosures within managed care, is, are we getting sufficient self-disclosures through the process. So we have these compliance requirements. We have these requirements for downstream providers. We have them for the managed care plans. Are they effective? And one of the measures of effectiveness is that it's finding overpayments in the Medicaid program and it's returning them to. That's just a premise that we have, that we're testing, and we're focused on enhancing the level of self-disclosure. It's for a variety of reasons. Self-disclosure is a federal requirement as well. There's a 60-day requirement that from identification that it be reported, that it be explained, and the dollars returned to the program. And indeed, we return the federal share as well, which the federal government is very focused on. There is a benefit to the provider as well. It definitely demonstrates compliance. Equally, it prevents them from being audited for the same issue, which could become much more significant issue in a larger audit, going forward. So the quicker that you're identifying the problems, you can mitigate that risk of a future audit, which could be very impactful. It's 100% in our self-interest as an agency as well to promote self-disclosure, because there's 560 of us and it's a $100 billion Medicaid program. So if we can encourage a culture of compliance, we can encourage appropriate self-disclosure, we can certainly increase our footprint, ensure that the dollars are going to where they're intended to go, which is to pay for the medical services that our recipients need. So, that's the importance that we place on compliance and self-disclosure, and we're doing everything that we can to encourage it. So I mentioned working with the provider community, working with the plans to identify it. One of the other areas that we're focused on is where you have an audit that's associated with a demonstrated period, there may be a self-disclosure that results out of that, either for prior periods or future periods, because that audit's only dealing with a certain period. It does raise the question about whether additional self-disclosures are necessary. One of the things that we're doing to try and address that is certainly communicate that and to place it in our final audit reports, language such as that, to say, hey, you may want to take a look at this same issue for other periods. And we're hopeful that that will be successful. Equally, as I mentioned, we're out conducting audits. If there's providers that have been operating for a long period of time and there is a very, very low level or no level of self-disclosure, we may want to ask that question as well. Anything that we can do to understand the issue and to, improve our response rates, or to identify that our response rates are appropriate, which could equally be the case.
Okay, very good. And you mentioned just in that overview, federal involvement. It's the first year of a very different federal administration. There's a lot of discussion about Medicaid funding overall, not just for home care services, but Medicaid funded services generally and nationally. Do you foresee, at least for this year, these federal changes, or at least talk of changes, impacting the number of audits you're doing, what you're focusing on, how much you intend to recoup? Do you foresee greater pressure to recover more money just because some programs more than others have been called out specifically at the federal level? Can you share anything at this point about?
Sure. I mean, certainly, reductions at the magnitude that are being discussed at the federal level, will impact all provision of services, kind of across the spectrum, and undoubtedly will create pressures and ripples, across our operations and direct us in one area or another, to address the challenges in the program. I can see kind of an increased focus, in identified areas, where trends are showing, spending may not be in alignment with what our current or future priorities are. Certainly, we're seeing it, now. Certainly the federal government is also changing the rules and the requirements that they're enforcing, where we were on a trajectory to, kind of deal with a lot of, sort of expenditures in the, sort of non-traditional or social determinants of health areas of the program. We're left questioning, whether funding is going to be available for those services through the Medicaid program going forward. Certainly we're trying to interpret and get questions answered by our program integrity, partners, at the federal level as well, to sort of identify what their priorities are and what they want us to do. So certainly we're cautiously optimistic. We certainly believe, and as the governor has sort of highlighted, that there are going to be substantial reductions in funding for our social safety net, and that will most definitely impact, kind of where we direct our attention, and even could impact our ability to, focus in those areas.
I had a quick question. An interesting topic of discussion would be the transition to the single FI, and I guess we can speak generally also about agencies closing. So what happens to oversight of those agencies that close, or what happens, say, to the bad actors who are in the fiscal intermediary space or the CDPAP space now that the program has shifted to the single FI? Is it water under the bridge? They're closed, or are they susceptible to, and you said it's retroactively, but the business is closed now, right? So what happens?
Yeah. So I think that, it's essentially we retain sort of the right to, look in the rearview mirror, and to take whatever action we deem appropriate. To use that example, nothing is going to be water under the bridge until that claims documentation period of anywhere between 6 and 10 years is expired. I think you can anticipate we will still be interested in enforcing and recovering any overpayments that are identified for that period. But certainly, as you have highlighted, to the extent that an agency is closed, that may provide, a barrier, to us to formally recover those dollars. But we will use every avenue at our disposal to recover those dollars. So in many instances, there may be opportunities even after closure in order to return benefits to the Medicaid program.
Okay. And then lastly, I don't want to assume that any policies or regulations that we see from OMIG are developed in response to problems that your auditors identify. But is there any sort of collaboration or cooperation that you would like to see from the provider community? Any sort of channels of sending maybe perhaps anonymous recommendations on how policies and procedures, enforcement guidelines could be changed and updated to reflect something that the business community, the provider community is also observing?
Yeah, I think that, we're interested in all sources of information, and we're open to all communication. This is one thing that I feel very strongly about. I'll take information from anybody, kind of warts and all, generally try to find something positive, to do with it. Certainly when we're developing policies, we're trying to incorporate the viewpoints of the provider community, in that. Sometimes we're trying to guess where the provider community will be best located or best served. We don't ordinarily get it right, but if we had, kind of recommendations from the provider community, they would not go unevaluated and unrecognized in the process. I think the regulatory process assumes, a level of provider review, a public review. And in my experience in state government, policies and procedures that we go forward with often result from a greater collaborations with the provider communities. I welcome it. I welcome recommendations. I am open to all communication, that comes in, the good, the bad, the ugly, and we want to address it. I think we have been successful, over the past few years. That's why I like to get out there, do speaking engagements, now podcasts, to sort of, get out there and sort of see what's happening on the ground, how we can successfully navigate. I've always been in my career, the truth is somewhere in the middle. Try to find that win-win solution. We're not always going to agree. More often than not, we're going to be able to get there. That's my goal. And, I think the goal of many, both here and, across state service, trying to kind of respond to all the constituents of the programs that we represent. So I'm always open, and I have never found the provider community to be shy about informing me where they have a better idea or I'm not doing what I should be doing. And I welcome it, because, what I don't know, that's the age old, tree falls in the forest and no one's there to hear it. Did it happen? I'd rather know than not know.
Thank you so much. We've covered a lot in just a little short than an hour. We've gone and did quite a broad overview of different areas that your office is working on, that we're always paying attention to as a home care attorney, as an operator. Any last questions, Sasha, before we close it off?
No questions, but I want to reiterate and thank you again for joining. I think we want to change the way advocacy is done, and we're glad that you're open to hearing from us. And I think we should have a regular line of communication when it comes to that. So
No, I couldn't agree more. And I would also sort of throw out for your viewers, we have an abundance of information that's available up on our website, from protocols to all the services that we have, to a work plan that explains what we're doing, and an annual report that comes out in the fall that tells you what we did do and how successful we were. And, certainly interested in any comments about those things. And then the final thing that I will call to everyone's attention: if you want to be in the know about what we're doing and what we're focused on next, please sign up for our listserv, where we push information out that is newsworthy, and, so that you can see, like, for instance, for anyone that's out in the Western region, we will be doing a provider engagement session in Buffalo, June 25th. And it's a great opportunity to come out, meet the OMIG and all the senior management staff, and get your questions answered firsthand. So I encourage you to take maximum use of all those vehicles, because we're trying to get the message out, and, we want to hear from you as well.
Thank you so much, Mr. Walsh.
all right. Thank you, Emina. Thank you, Mr. Walsh, for joining us. I hope you've enjoyed this podcast as we have. This has been the Home Care Forum podcast with your hosts, Sasha, Guillaume, and Emina Poricanin. Have a good one.